Okay, so we've got a few folks online as well. So we'll just start by saying welcome to the February 27th inaugural Lakeridge Health Department of Family Community Medicine Education Rounds. Glad to have everybody with us today, a couple in person and more online. So that's great to see the hybrid opportunity. I'll just ask people online, is everything working with this sound? People are good to hear us? Or well, just tell me if you're not. I'll assume. Oh, I see some thumbs up. Thank you. Perfect. So we'll just jump right in. So I'll introduce myself first, even though Joel's name is on the slide first. But I'm Shannon Burke. I'm Director of the Department of Family Community Medicine, as well as the Central East Regional Cancer Program and Indigenous Cancer Program. And happy to be with the group today. And I'll hand it over to Joel.
Hi, everyone. I'm Joel Kennedy, and I am the Chief Medical Director for the Department of Family Medicine, which is in its, I think, third year now, as a much needed rebirth of our Department of Family and Community Medicine. And we're very excited to launch an education series that will be held monthly to help everyone get local CME credits and help with navigation and practices in the area. We're going to run through some housekeeping, and certainly if you have questions, put them online. And if you have ideas for other topics you'd like to have, please put them in the chats as well. I'm going to hand back to Shannon to run us through housekeeping and introduce our first sets of speakers.
Great. Perfect. So those online, you'll have to find your own washrooms. I can't help you there. And you also don't get access to our vendor tables. But for those in the room, washrooms are close by, just out the door to the right. And there's some tables at the back with lots of swag. And please feel free to help yourself with all of that. There also is a sign-in sheet at the back, which I think we're good with. Those online we'll take your attendance virtually, all good there. Today, our plan is for two different presentations, one from Ontario Health at Home. We have Melina Perron with us, who's going to speak to some of the great services that are available to primary care to bolster your team. And then we have the team coming from the chronic heart failure ICP group, so to present on that great work. We will have a break in between the presentations. It was meant for networking, but if you're online, we can leave the channels open and you can chat amongst yourselves, or I imagine people will go off and do their work in between the presentations. But we did have breakfast here. You guys missed out. So anyway, also this is MainPro certified, so you will get a attendance certificate emailed to you next week sometime. And then at the end, please fill in our evaluation so we know how to make this better and more relevant for you next time. So at this point, I'm going to hand over to Melina. I'm just going to check online as well. Can you see Melina's presentation? The Ontario Health at Home presentation, is that what is sharing online? Yeah, perfect. Okay, thank you. Thanks for those thumbs up. Perfect. Okay, over to you, Melina. And you're just going to have to press the down arrow. It's not telling you there, but okay. Okay.
Hi, everyone, and thank you. My name is Melina Perron. I am a Director in Patient Services at Ontario Health at Home. I'm a registered nurse by background. Thank you very much for inviting me here today to speak about home and community care in Ontario. So really my passion for home care began long before my career in home care. It really started with my grandpa and his decline in health. Although we rallied around him as a family, it's his home care team that really was able to keep him home with dignity and do the things that we didn't want to really do as a family, such as bathing, etc. And that's really where my passion stemmed from. So I'm here to talk about it today. Oh, press down, you said. Up. Side. No, none of the things are working. Oh, I have to push there.
Like down, yeah. Down on that one.
Down on here?
Yeah.
Okay. All right. So the learning objectives, by the end of the session today, you'll be able to define the role of Ontario Health at Home within Ontario Health teams, including care coordination, shared services, and system integration with primary care. Identify Ontario Health at Home programs and services relevant to primary care practice, including eligibility considerations and how to access. Select appropriate Ontario Health at Home referral pathways for common primary care clinical scenarios, including post-acute discharge, frailty, wound care pathways, palliative care, mental health, and community support services. Describe how care coordination supports safe transitions across care settings, including hospital to home, emergency department, diversion, and long-term care placement. And explain how Healthcare Connect process and provide a role in patient attachment, including prioritization criteria and collaboration with care connectors. Not losing it, Shannon. Mhm.
Won't go to the next page. It's very strange. No, I just have it by PDF.
There we go.
Okay.
Okay, try this again. Okay, so as mentioned, Ontario Health at Home plays a very important role in Ontario's healthcare system. So each year we support over 680,000 patients of all ages to remain safely at home with the support of health and other professional services. To do so, we partner and collaborate with many of the partners in the system. As you can see here on the left, so patient caregiver advocates such as the patient ombudsman, Indigenous partners, other government partners such as the Ministry of Health, the Ministry of Long-Term Care, long-term care and retirement homes. Oh. Organizations such as Veterans Affairs Canada and the RHRA, which is the Retirement Home Regulatory Authority, local and municipal programs such as public health, housing, family and children's services, and then health system partners such as our hospital partner here today, the College of Nurses, the Ontario Hospital Association. On the right is a list of all the partners we work with directly to deliver home and community care services. So you'll see here that there's over 100 equipment and supply vendor sites, over 600 long-term care homes, over 750 retirement homes, 72 school boards, and over 100 service provider organizations. Ontario Health at Home is a subsidiary of Ontario Health. So we work closely with Ontario Health to support our business planning for the future, including embedding home and community care into overall health system planning, leveraging broader system metrics to inform our business planning, and collaborating with Ontario Health to shape the future of home care and the priorities that guide our work. So in Ontario, we have 7 leading projects underway. The Leading Project Initiative was launched to identify opportunities to establish new models of integrated care and provide insight into various planning options and complexities that will need to be addressed in home and community care modernization. As mentioned, there are 7 leading projects that are underway across the province, and we've been involved in the planning from the very beginning. Oopsie. A number of Ontario Health at Home care coordinator staff have been embedded into the leading projects. And the goals were to test and evaluate OHT-led home care models that improve care integration, access, and patient outcomes and experience. To build health system capacity for home care planning, delivery, and integration, and inform potential scale and spread of new models of home care. So we'll take these lessons learned from the leading projects to inform how we'll embed care coordination within integrated care teams in the future. Ontario Health at Home helps people find the way through Ontario's healthcare system, understand their options, and connect with community-based healthcare resources. We help patients and families and caregivers when they need services, support, and guidance to really remain at home safely with the supports of health and other care professionals to transition to long-term care or other supportive housing, leave the hospital and recover at home, avoid visiting the emergency department when possible, die with dignity in the setting of their choice, and find a family doctor or nurse practitioner, and find community services that support healthy, independent living. Sorry. Okay, so before we get into how we help, let's start with where we work. So our staff help patients in the community by acting as a first point of contact to connect people with a broad range of community and social services, such as Meals on Wheels, adult day services, exercise and falls prevention classes, and more, such as access, intake, and navigation. Our staff help patients in homes and neighborhoods by working with patients in their homes for as long as possible to promote independence. And they help patients in hospital by being on site and working with them to help transition home or to long-term care home. Care coordination. A major component of what we do is care coordination. Care coordination is an important component of our healthcare system. We do follow the regulations under the Connecting Care Act for the Ontario Regulations 187-22, which is Home and Community Care Services. And this defines care coordination as the services required to facilitate access to and coordinate the provision of home and community care services to patients, including assessing and reassessing patient requirements, making determinations of eligibility, developing, evaluating and revising care plans, making referrals to other providers, and terminating the provision of a service when appropriate. This regulation, which came into effect on May 1st, 2022, outlines the guidelines for the delivery of care coordination services. So in 24-25 fiscal, Ontario Health at Home care coordinators completed over 673,000 assessments. This is the placemat to the care coordinator patient care journey. This is a typical patient care journey from the time of referral until their discharge or transition to other care destinations such as assisted living, long-term care, retirement home. So services are determined based on the needs assessment done by the care coordinator. So here we start really at the beginning, where the patient is referred to us, whether by self, family, caregiver, primary care, hospital partner, paramedics, or other community partners. The care coordinator then takes that time to assess the patient, determine their needs. They discuss their needs and goals. They provide navigation and support. They complete referrals to other CSS or community support services such as Meals on Wheels, etc. Then they determine the care plan, and they'll implement services such as nursing, personal support, occupational therapy, and the list goes on. And then we integrate with the care team. So we really try to keep those lines of communication open between primary care, service providers, vendors, just to ensure that the services are meeting the goals of care for that patient and their care team. Service delivery, so care coordinators also deliver education, navigation, problem solving, advocacy, and ongoing assessment. Medical equipment and supplies and other publicly funded and non-health services. And then patients are reassessed either at regular intervals or when they have a change in their health or life situation. At which point care coordinators respond, they'll reassess, readjust service levels, make new referrals as needed, and then just provide ongoing monitoring of a patient until a patient is transitioned off of our care, whether it be into long-term care or they've passed away, etc. Gosh. Okay. To ensure the right care in the right place at the right time, Ontario Health at Home uses a population-based approach to meet the needs of specific patient populations. So we have short stay, community independent, chronic, complex. The standardized model enables us to provide consistent, specialized care coordination that result in quality care and improved outcomes for patients. Using a population-based approach to the way a hospital approach, so patient acuity. So the following criteria are considered when we're categorizing patients into population groups: their health conditions, socioeconomic factors such as social supports, housing needs, finances, their degree of independence, risk of experiencing acute care episodes, anticipated resource utilization. So the larger population at the base is really the well. They typically require things like system navigation or connecting to other services. And the smaller population at the top are our more complex patient. Persons can move up and down the triangle between the different populations as their care needs change. And an acute episode can occur at any time really through the population group, but are more likely as their care needs increase. As you can see on the left here by the numbers, over 18% of adult patients are complex, over 48% are chronic, so that's the bulk of our patient population. Just under 10% of adults are community independent, and then almost 24% are short stay, with less than 1% being well that come onto our services. So anyone can refer someone to Ontario Health at Home. Like I said, it could be self-referral, family referral, primary care, hospital, schools. As you can see, hospitals are really our number one referral source, representing almost 51% of our total referrals in 24-25. We have seen an overall 7.4 increase in the amount of referrals throughout the province, though. And in 24-25, we received 782,000 plus new referrals. And you can just see more statistics here at the bottom. Okay, so one of the programs we offer is called self-management. Self-management program in Central East offers free self-management workshops to empower patients or caregivers to take charge of their health while living with health conditions such as diabetes, heart disease, arthritis, lung disease, and other chronic health issues. The program also offers a variety of training for healthcare professionals. So in order to refer a patient or caregiver, you would refer to home care, and we would make that referral to our internal self-management program. And otherwise, I can share the resources out with Shannon afterwards to provide you with our website and how to make a referral. Okay, so in the community at Ontario Health at Home, our programs fit into one of four classifications: care coordination, direct care, and nursing clinics, integrated programs, navigation, and referral. So we will explore these a little bit further. As I mentioned earlier, care coordination involves assessing a patient's unique needs and developing a care plan that may include nursing, PSS or personal support, physio, OT, and other specialized programs with care delivered by service provider organizations. In 24-25, with the support of over 100 service providers, we provided 11.1 million nursing visits in homes and clinics, 44.4 million hours of personal support, and 1.6 million hours of therapies. Direct nursing services. So these programs are offered by internal clinical staff and contracted service providers to support certain patient populations. So our clinical care coordinators provide direct care nursing and intervention while partnering with the identified patient and their circle of care to develop a comprehensive coordinated care plan. So some of our direct nursing services include mental health and addictions nurses. Those nurses typically work with patients in schools. Rapid response nurses, telehome care nurses, and nurse practitioners. We have three types in Central East, and it's primary care, palliative care, and long-term care. In 24-25, over 55,000 visits were made by mental health and addictions nurses. Over 44,000 visits were made by rapid response nurses, or RRNs is what we call them. And then for our palliative nurse practitioner team, we made over 6,700 visits. At Ontario Health at Home, we have a clinic-first approach to nursing. This means that all eligible patients referred to us for nursing services will receive their nursing care at a community clinic. The clinic-first approach enables the most effective use of health human resources and helps patient receive the right care at the right time and in the right place. Of course, patients who are unable to attend a clinic would be assessed for in-home nursing services or other rehab, restorative, personal care services as well. Our community nursing clinics are staffed by internal clinical staff and contracted service providers who provide specialized nursing services, including wound care, IV therapy, urinary catheter care, and other nursing treatments. It's by appointment only, and many have extended hours, including evenings and weekends, to help patients avoid unnecessary ED visits. The benefits of a clinic-first approach: it increases the clinic use to optimize our HHR capacity, staff retention, and medical supply efficiency. It leverages best practice to achieve optimal outcomes, and it frees up visiting nursing capacity to patients who absolutely need the in-home care. In 24-25, there was over 140, or we have over 140 community nursing clinics across Ontario, providing care to nearly 117,000 patients through almost 1.5 million visits. Our care coordinators help children and youth who need extra care and support to thrive in school. This might include public schools where we're offering nursing and dietetics, home and private schools where we're offering occupational therapy, physiotherapy, SLP, nursing, dietetics, and personal support. These children and youth are typically medically fragile and need care and support to live at home safely. And a lot suffer from mental health and addiction challenges. So in 24-25, we supported nearly 30,000 children. Just over 12,000 of those children received nursing, allowing them to attend school. And we brought over 14,000 complex children home from hospital and supported 183 palliative children. Okay, navigation, access, and intake. Care coordinators are really expert health system navigators and they have an intricate knowledge about the health system, community resources, and social services. Care coordinators assess a patient's unique needs and develop a care plan that might include adult day program, falls prevention, behavioral supports, Meals on Wheels, and other community support services. In 24-25, we completed just over 60,000 referrals to community support services. All right, in hospitals, working on site in hospital and emergency rooms to help people make the transition home or to long-term care. Because over 50% of our referrals come from hospital, we have embedded care coordinators working on site at 150 of our hospital sites across the province. They're embedded in inpatient units, outpatient clinics, emergency departments, and more. They help patients to transition back home with home care supports. For those unable to return home, hospital care coordinators help make long-term care arrangements. They play an important role in preventing hospitalizations through our ED diversion programs. They also support hospital flow by implementing ALC best practices, and they play an important role in counseling ALC patients on and potentially making long-term care selections under Bill 7. We supported over 216,000 patients transition out of hospital in 24-25 fiscal. Long-term care. Ontario is home to 611 long-term care homes and counting, which house over 78,000 long-term care beds as of March 31st, 2025. And there's more coming up every day. Long-term care homes are licensed and funded by the Ministry of Long-Term Care. They're governed by legislated standards and inspected annually. We manage the long-term care placement and wait lists for the province. Provincial legislation allows people to select up to 5 of the 600 long-term care homes. Patients may request a long-term care home anywhere in the province, in their own community or closer to a family or caregiver. And long-term care homes rely on integration with Ontario Health Solutions to receive and respond to patient applications. So in 24-25, over 25,000 patients were admitted into long-term care. Now I'll speak about Healthcare Connect. So the Primary Care Action Team is an initiative, which I'm sure many of you are aware of, created by Ontario's Ministry of Health to strengthen and expand access to primary care across the province. It was formally established on December 1st, 2024, following the success of earlier expansions of primary care teams. So what does this team do? It expands primary care teams, it closes gaps in access, and lastly, it builds long-term province-wide plan by designing and implementing Ontario's Primary Care Action Plan, which outlines really how this will be achieved. This includes funding models, workforce planning, integration with home care, mental health and community services, and improving convenience and continuity of care. So at Ontario Health at Home, we have healthcare connectors who are supporting the primary care action plan. It's an alignment and in collaboration with OHTs, so care coordinators aligned to lead outreach with all 58 OHTs and their primary care networks. They're engaging OHTs to better understand local capacity and support streamlined, expedited patient to primary care attachment process, create a more efficient, coordinated system that balances provider capacity with patient demand, and focus approach aligned to available resources. So patient registration with Healthcare Connect, they can register online at ontario.ca /healthcare connect, or by calling 811. It's 24 hours a day, 7 days a week, and services are available in multiple languages. Patients must have a valid Ontario Health or OHIP card. Once registered, patients are prioritized. So they'll receive a letter in the mail from the Healthcare Connector confirming their registration. Individuals are prioritized on the list based on the acuity of their healthcare needs or conditions. And when the individual is matched to a primary care provider, the care coordinator will contact the individual to connect them with the family doctor or nurse practitioner. And the care coordinators are able to are able to support care coordinators in looking to connect their patients with primary care providers. So patient priorities are children under 2, pregnant patients, people with complex health conditions such as mental health, diabetes, cancer, respiratory issues. And then families indexed together are based on the highest ranked member score. Primary care registration and Healthcare Connect. So they connect with local OHT and primary care networks and or call the care connector. There's 45 care connectors. I keep meaning to say care coordinators. 45 care connectors across Ontario, and we have 4 of them in the Central East region. So Durham, Scugog, Brock, Scarborough, Peterborough, Haliburton counties, and then City of Kawartha Lakes and Northumberland. The benefits to providers working with healthcare connectors, developing working relationships with community partners, patients with highest care needs are prioritized, assist to build and balance providers' practice, physicians on income stabilization can accept patients through Healthcare Connect, new physician grads can accept patients through Healthcare Connect, and outsourcing patient wait lists. So for example, patients join the Healthcare Connect centralized waitlist for care connectors to maintain. And then there's some incentives available for physicians enrolling patients. Oh, sorry, I forgot to change that slide for you. This is what I just said. Okay. And then that one I won't speak to. And that's really it. So thank you once again for inviting me to talk about home care in Ontario. And I will stop here and open it up to questions. And I don't know if there's questions online. Okay. Oopsie. Thank you. Yeah. It happens at the assessment piece of it. So the patients are registered and then assessed. Yeah. Okay.
Service that would benefit primary care. What's the takeaway of primary?
I would say just in my own personal experiences, probably our nursing clinics and nursing services, particularly for wound care, maybe even IV, those types of things for patients that are visiting urgent care departments, not necessarily the ED visits, but more the walk-in clinics and returning to those. That those patients can be referred to home care as well for our nursing clinics for ongoing wound care, etc. Oh, okay. Shannon asked, when is a patient determined or prioritized when being connected with healthcare connectors? And I just said it happens, they're registered and then assessed, and that's when that determination is made or prioritization is made. Oh. Yeah, and the second question was, what is the most important consideration for primary care? And I just said that nursing is probably most underutilized, I would say, for primary care. Don't hesitate to refer to home care if your patient requires wound care, IV. For wound care, the nurse will assess and then communicate back to the primary care provider. So even if you're not 100% sure what to write on the referral, it's okay. Just write wound care and the nurse will assess and then communicate back to yourselves to let you know of the treatment plan moving forward. Yeah, so certainly if that patient requires assistance with any type of personal care, we can support there, or our care coordinators can make referrals to other community support services. So Community Care Durham is one of them, and they'll assist with transportation. They have friendly visitor programs, etc. So there's a lot of services out there that we can support with. Yep.
How close are we to achieving that 2029 connected?
That I'm really not sure of, to be honest, but I can look into it and get back to Shannon. And I think we're making good headway. Yeah, I think so. Or do we want
To the podium, It's the laptop, you want to go on, Melina? Yeah. Get in there. Good question.
Just rephrase the question.
Yeah, repeat the question and see it. It's the laptop.
Oh, it's the laptop.
The laptop, am I using this one?
No, I think you just
All right,
stand
we're
there.
going in, we're getting in. Hi, everyone. So just want to provide a bit of an update on the Healthcare Connect. So fantastic that Melina was able to speak to that. So certainly the Ontario Health teams are working in partnership with OHA, with our fantastic care coordinators in the East region. And so the first goal of the primary care action team that Jane is tasked with achieving is clearing the Healthcare Connect list as of January 1st, 2025. So just within this year, we notionally have been cleared. And so we had close to 7,000 patients that were on that Healthcare Connect waitlist up until January of 2025. So we have cleared that. We are right now about 91.8% attached within the Durham region, according to our performance framework that OH provides us. And so our next goal is to achieve 100% attachment within the Durham area by 2029.
Yes, that's a great question. And we were just given guidance within the last few weeks around the prioritization and to the point about connecting that to their local FSAs, which is their postal codes. So to your great point around, we don't want folks traveling 2 hours to receive primary care. So the guidance now is to have that attachment within 30 minutes to a primary care provider that is accepting patients. We know that not everyone knows about Healthcare Connect wait lists, and that also is for providers, but also patients. So we're working very closely with our partners at the Ministry, Ontario Health, at OHA to have a really streamlined communication strategy, so that folks know where to go to be attached. But there's many pillars that are coming into that work. So we know that Healthcare Connect is one leg of the broader solution, but certainly we'll need to look at other avenues that, folks that are not on the Healthcare Connect list. So we have different, I guess, avenues to get into how we address the unattached waitlist. Certainly, we're working with our partners at Lakeridge. There are strategies that are happening. We have virtual strategies that are happening. So there's many different pieces to the puzzle because we know that, Healthcare Connect list solely won't be the only solution. Or repeat of the question. So I think one of the questions that came from the room was around how do we address patients that might be traveling over 2+ hours. So the new guidance that just came out for 2026 is that we certainly want to look for attachment within 30 minutes of where that patient resides. Sounds like I'm hearing something.
Melina, question for you. After transfer to long-term care, who coordinates PT and OT, etc.?
The long-term care home is responsible for providing those services in long-term care. We do provide some by exception if the long-term care home is having a difficult time securing a provider, but those are by exception.
And then could you explain more about what choice the patient has in choosing a long-term care once picked up off the wait list?
Yeah, the legislation is clear that the patient or their legal substitute decision maker, if the patient is incapable, is making those decisions. So they have an open choice of picking any long-term care home within the province. If they wanted to be closer to their loved ones in Thunder Bay, they could pick a home in Thunder Bay. It really depends on the urgency that patient needs to get into long-term care. Some of our wait lists are quite long. It really depends on the patient's situation, their status, etc. But the choice is theirs on which homes they're picking. They can pick up to 5 for a regular long-term care home application. They can pick more if they are in a crisis situation and have been determined crisis.
And just another question, will the referral form for home and community care support services suffice to get the patient support? And how long is the wait list for this? And I think that's back to the patient who's starting dialysis and has no family support in Canada.
Yeah, that's a great question. So our referral form is online, and I can share the link to it after this presentation as well. We typically try to call the patient within and assess them within 5 days of referral, but it really is determined on the urgency. So for instance, if the hospital sent us a referral for an IV start for today, we would assess that patient today. If you're just referring for perhaps a referral to community support services or personal support, that referral may take up to 5 days. And we would communicate back with a primary care provider using our primary care communication tool and fax that back to your office to let you know that we've assessed the patient. These are the services they're receiving and any other information we might think is valuable for you.
Perfect. Oh, one more question coming.
Yeah.
Oh, just thank you.
Oh, thank you.
That's great. Oh, and Dr. Kennedy has put the link in the chat there. For
Great,
folks as
thank
well.
you.
Awesome. Okay, well, that's great. So thank you so much, Melina. Lots
you.
and lots of information in a short period of time about all the services and great things that are provided through your organization. I think to me, it's such a benefit to primary care because it extends their team, right? Outside of who they have in their office, home care can really be part of the primary care team and supporting their patients. And you have all the great allied health professionals that will help really give that comprehensive care. So that's great to hear about. Wonderful.
And sorry, one last plug that I would say is if you're not sure what your patient might be eligible for, what they would benefit from, you can always make a referral. We have a checkbox on our referral form that says case management assessment, and that would allow the care coordinator to do an assessment and determine what the patient might be eligible for.
Amazing.
Yeah,
That's great.
thank you.
Perfect. That's wonderful. Okay, and so for folks on the online, we're going to take a short break while we switch over to other presenters. So I think the other group is ready to present. They had some clinical commitments this morning, so they're going to be available to present at 10:30. So please feel free to jump off, get yourself some breakfast because you're not eating ours, and we'll see you back at 10:30 for the next presentation. Thanks so much.